Bismillahirrahmanirrahim. Hello friends, how are you? One of my friend has requested me that you have to start the MCQ series. So I have started with the first topic of my MCQ series, that is cholelithiasis and cholecystectomy. I will start with the cholelithiasis and then we'll go how to treat them with in a stepwise manner. First of all is cholelithiasis. Cholelithiasis means stone in gallbladder. Stone in the gallbladder is called cholelithiasis. It is different from choledocholithiasis, which is stone in CBD. Stone in CBD. These both topics are important for us. So first of all, I will discuss cholelithiasis, and then in a stepwise manner I will go to choledocholithiasis, and finally how to treat both of these conditions. They are very important MCQs, talks, short case, long case. Practically in every aspect this topic is very important. MCQs, which queries which were asked from me and come across, I will repeat them and will then go forward. One is difficult cholecystectomy management. How will you approach the difficult cholecystectomy? Then during laparoscopic cholecystectomy, anatomy of the carotid triangle is not clear. How will you proceed next step? Then during cholecystectomy, you find CBD stone 1.2 centimeter. What will your next plan of management? All these MCQs and many more will be discussed in this next 5 or 10 minutes. So keep in touch with me. First is the gallstones. How gallstones are formed? There are cholesterol stones, there are brown, and there are black, and also mixed. Forget about them. The most important is cholesterol, in which greater than 30% of there is the cholesterol. In both these there are less than 30% of the cholesterol. One thing very important, cholesterol is mainly a thing of the gallbladder. You will cholecystosis are the conditions in which are treated by cholecystectomy, like strawberry gallbladder, granulomatous conditions of gallbladder. All these are cholesterol based. Cholesterol stones are mainly concerned with the gallbladder. Brown stones are mainly concerned with the CBD. These are the culprits of choledocholithiasis, brown stones. But these cholesterol stones can also go into the CBD as the secondary stones. Brown stones are the primary stones of the CBD, and they are formed in a parasitic infestations or any foreign subject left there, chronic infections, they can cause burn. Black stones are also very important for you, and they are related with the hemolytic conditions. So these three stones are very important, and I have highlighted why they are important. Black stones are related to hemolytic conditions, in which if there are black stones in the gallbladder, hemolytic condition Along with cholecystectomy, you will also do splenectomy as well. These are the conditions like hereditary spherocytosis. So you will do both operations, splenectomy as well as cholecystectomy. I have covered one MCQs here regarding these hemolytic conditions. Brown stones are mainly concerned with the CBD. Cholesterol stones are related to the gallbladder. After knowing the types of gallstones, important types mixed as well, but forget about them. Now, how they are formed? Stepwise, they are formed as lithogenic bile formation. First of all, lithogenic bile formation. After that, there is nucleation of already formed nucleation of unstable vesicles, and after that there is stasis, sludge formation, and finally stone. This is the stepwise progression from formation of lithogenic bile to nucleation of cholesterol monohydrate crystals. Then there is stasis with added infection, sludge formation, and finally stone formation. I have covered this in 2-3 lines. Okay. The most important is the first one. Other things can be added, but the most important is the first one. So I will. What is lithogenic? By the way, what is white bile? White bile is formed in the Marie syndrome. Marie syndrome, white bile is formed. Lithogenic bile is related to the gallstone formation. How? Normal ratio of bile salt to cholesterol is 20 to 1. It's called critical ratio, 20 to 1. When this ratio is disturbed, it results in the formation of lithogenic bile and then stepwise progression to stone formation. How? Increase in cholesterol, decrease in bile salts, decrease in enterohepatic circulation. All these are the culprit of forming lithogenic bile and then the stepwise progression to gallstone formation. Increase in the cholesterol due to 5 F's: 40, fertile, female. All these are obesity as well. Decrease bile salt formation due to medications, decrease enterohepatic due to ileal dissection. These are the causes of ultimate gallstone formation. There is no confusion in that. I have simplified them. Now, once gallstones are formed, what they do? At looking at the picture, it will be very clear. So, this is your gallbladder. This is your cystic duct. It is opening into the CBD. That is your short length right, long length left hepatic duct. Short length right, long length left hepatic duct. This is your CBD. Normal is 6 to 7 millimeter. 6 to 7 millimeter is the diameter of the CBD. It has 4 parts. Final part is going through or behind the pancreas, and it joins the pancreatic duct opening by a single major papilla into the second part of the duodenum. All this anatomy is important for you. I will elaborate it further for clearance. Left hepatic duct, right hepatic duct, segment 2, segment 3, segment 4, 1, one smaller, 4, 5, 6, 7, 8. These are Conard segments. They are divided by this cantle line of the middle hepatic vein into the left and the right liver lobes. Now I am making portal vein posteriorly, P portal, P posterior, P portal, P posterior, and I am making hepatic artery interior, portal vein posterior, and to the right is the CBD. All these three form contents of foramen of Winslow. Foramen of Winslow. Which is the communication between the lesser sac posterior to the stomach and the greater sac. This is the communicating foramen between the lesser sac and the greater. These are the segments of the liver. 2, 1, 2, 3, 4, 5, 6, 7, 8. Let me further elaborate them for your ease. This left lobe is again divided into the lateral and medial by the falciform ligament. And right and left lobe are divided by the middle hepatic vein. There are three veins of there are three hepatic veins: right, left, middle. Three hepatic veins. Important ones are middle, which divide right and left lobe, and then is the right hepatic vein. Left hepatic vein then joins the middle before entering into the IVC. So middle hepatic vein, this is middle hepatic vein, divide left and right, and then the right hepatic vein divide further the right lobe into the anterior and posterior. 5 and 8 are anterior lobes segments. 6 and 7 are posterior. Liver by itself is covered by Gleason capsule. I think this is sufficient. One is also called caudate lobe, and 4 is also called quadrate lobe. Cantle line, this line which divide is cantle line. This is the liver anatomy for your information. Then further going, I have described the foramen of Winslow as well. The Pringle maneuver is basically to occlude this foramen. First we have to make hole here, and then by thumb and index finger we can occlude this, and for time for Pringle maneuver is 15 minutes. 15 minutes is the time for Pringle maneuver. Warm ischemia time is something different. It is 45 minutes for the liver. 15 minutes Pringle maneuver. Then it is called ampulla of Witter. ampulla of Witter formed by joining of the pancreatic major duct and the CVD opening into the second part of the duodenum by major papilla. Okay. Other important thing is arterial supply to the CVD is in a 3 and 9 o'clock position, and on ultrasound these three structures look like Mickey Mouse character. It is sufficient for you. Then is the important node here. It is called lymph node of Lund. Lymph node of Lund. In this triangle is formed by the cystic duct, inferior border of liver, and this right hepatic duct. Right hepatic duct, inferior border of the liver, and cystic duct this form. And the content here is cystic artery. Cystic artery. Cystic artery. This is the Kelch triangle. Okay, after going through the anatomical details of all these areas, now let's go into a detail. When there is a stone here, what he do then, or it do? Suppose stone is here, silent, saying nothing. It is called cholelithiasis. But it is important that if this silent stone is in the hypertensive patient, diabetic patient, immunocompromised patient, patient with hemolytic disorders, then we have to operate. Otherwise we can leave it as such, but leaving it as such has consequences. Suppose a silent stone here, suppose a silent stone here. Silent stone without any cry, silent stone, saying nothing, just there. But at least there is a pathology. What it can do, its presence, it can erode from the neck into the CVD in a stepwise manner. It's called Marizzi syndrome. It will pressurize the common hepatic duct, resulting in Marizzi syndrome, and operative finding will be white bile. But in the acute state we don't have to operate. We will not do cholecystectomy in the initial phases of Marizzi syndrome. Later we can do, but not in the initial stages. Suppose a silent stone in the body, it can erode into the second part of the duodenum and go to the ileum, can cause gallstone ileus, gallstone ileus. Silent stone saying nothing, just present, can do. And now when it starts saying something, what it can do? Suppose here with the on and off attacks, it can reproduce, making other stones, multiple stones. Ultimately its presence, its attacks, patients is tolerating, it can take a chronic form, chronic cholecystectomy. cystitis. But mostly and the chronic cholecystitis can ultimately end up in formation of CA gallbladder. That is the main culprit, although there are other causes of CA gallbladder, but chronic cholecystitis is one of the cause. Patient history will be patient has a long history of right upper quadrant pain. He was previously admitted. He refused to operate. Patient had gallstones, but at that time he didn't make his mind, and the stones were there, saying nothing to the patient, ultimately ending up in the chronic cholecystitis gallbladder CA formation. Ultimately, we'll go how to manage them, but so far we are studying the complications of gallbladder stones. Suppose a stone stuck here in the Hartmann pouch, what it can do? It can take a form of biliary colic, and then ultimately one attack or 2-3 attacks of biliary colic, it can take the form of acute cholecystitis. That is the main of our concern area. Acute cholecystitis can be due to stone hair, or it can be without. Acalculous cholecystitis is called acalculous cholecystitis. Cholecystitis is basically inflammation of the gallbladder. When there is a stone, it is the culprit. When there is no stone, it can be due to infections as well, like typhoid, like Clostridium can also cause Salmonella, E. coli. These are the culprits behind causing cholecystitis. Clostridium cholecystitis is called emphysematous cholecystitis. Typhoid cholecystitis, ultimate treatment is cholecystectomy of all these conditions. Acute cholecystitis, normal history which we come across, and we have to mainly concern with these pathologies are patient with biliary colic, ultimately ending up into the acute cholecystitis. Acute cholecystitis ultimately changing into chronic cholecystitis. Chronic cholecystitis into CA gallbladder. So, what is biliary colic? How it is different from intestinal and ureteric colic? Biliary colic, listen to it carefully. It will stay there 45 to 1 hour. 45 to 1 hour biliary colic will stay here. Its total duration will be less than 24 hours. After 24 hours, the condition will be called acute cholecystitis, which is then diagnosed by Tokyo guidelines of clinical signs of Murphy sign, Monahan sign, Swass sign. These are clinical signs of fever along with that. And radiological, especially ultrasound features of various cholecystatic fluids, thickening of the gallbladder wall, presence of stone there with acoustic shadow. There is another complications of the same acute cholecystitis especially when stone is here in the neck. Mucocele formation, and mucocele can ultimately end up in empyema gallbladder formation. And when there is a fever along with mucosa, then it's empyema gallbladder, especially is a toxic condition in diabetic anemia patient. Finally, emphysematous empyema gallbladder can change into perforation of the gallbladder, ending up into the peritonitis, biliary peritonitis, and uh, so on and so forth. So we have started with the gallstones, its formation. Then we are discussing its complication, in which the rare one, Marizzi syndrome, gallstone ileus, acute cholecystitis, chronic cholecystitis, CA gallbladder. And now when this stone escapes from the cystic duct and goes here in the CBD, what it can do? Stone here in the CBD, silent, nothing to worry. But it is not silent here. It presents with Charcot striate, and Raynaud pentard. Obstructive jaundice. One of the differential diagnoses of, and the most common differential of obstructive jaundice is CBD stone. Stone here, allowing passage of bile down, is not that much to worry about. But impacted stone here is the clear-cut obstructive jaundice, present with features of obstructive jaundice with Charcot striate, cholangitis it's called. The most important bacteria are keep groups: E. coli, Klebsiella, Enterococcus, Pseudomonas. These are the groups causing cholangitis, Charcot striate. And then when there is a shock condition, patient is unconscious, then it's called pentard. A stone in the, we have started our journey from cholelithiasis, ending up now in choledocholithiasis. I have discussed all these common complications of stone in the gallbladder and what it can cause. Ultimately, stone here, stone here. Then how we will manage each of these conditions? Let's discuss them shortly. So, patient presenting with biliary colic. Patient is acute cholecystatic with signs of Moynihan sign, Swas sign, Boas sign. There is, when on deep inspiration, there is tenderness just below the tip of the ninth rib. It's called Murphy's sign. These signs which you are look for, patient will be a representative of female, 40, fertile, fatty lady. Cholecystectomy. Let's straight away go to cholecystectomy. Cholecystectomy is the ultimate solution of the many problems of the gallbladder pathologies. It can be open, it can be laparoscopic. Gold standard is laparoscopic cholecystectomy. Open can be total, subtotal, mini, index, interval. Then we can further go into, it can be simple, it can be extended or radical. Cholecystectomy. Gold standard is laparoscopic, especially it addresses many of the pathologies of the gallbladder. It's the gold standard. Laparoscopic cholecystectomy can be 4-port, 3-port, 1-port, cholecystectomy. 1-port, 15 mm port, 3-port and 2-port, there is no difference. In 3-port, the fundus retracting, the fourth one which is applied at the, let me discuss further, because it is also including the talk station, so I will further describe it. That is optical port, camera 10 millimeter port, that is the 5 centimeter below xiphoid, right left of falciparum ligament. It is falciparum ligament is not injured. 10 millimeter clip applicator port, specimen retrieval port, epigastric port, and dissecting forceps is introduced to it as well. Then is the third port, both mid-clavicular line 5 millimeter port is used. Then interior axillary line at the level of umbilicus, another 5 millimeter port is used. These 4 ports are important. In 3-port we eliminate this one, and in the 1-port we just use a single port, camera, dissecting forceps, retracting forceps, all these are introduced to a single. So it is laparoscopic and it's the gold standard, especially in a conditions of gallstone pancreatitis. Gallstones can also cause pancreatitis as well. That's called gallstone pancreatitis. When patient is recovered from pancreatitis, he can go for laparoscopic cholecystectomy. Gallstone pancreatitis, laparoscopic cholecystectomy is the gold standard. I have discussed interval index cholecystectomy in bariatric surgery. The cholecystectomy we do is index cholecystectomy. Interval cholecystectomy is when cholecystectomy is done after 6 weeks of episode of acute cholecystitis. It's called interval cholecystectomy. Early laparoscopic emergency cholecystectomy is when it is performed within the 78 hours of the patient admitting in the hospital due to acute cholecystitis. When it is performed within the first 78 hours, then it is early laparoscopic emergency cholecystectomy. Then is the subtotal, they are perform in the conditions of empyema gallbladder when Carnot's triangle and not V is not clear. Carnot triangle I have already discussed the main important what are its boundaries. Then is the simple cholecystectomy is just the removal of the gallbladder. Extended cholecystectomy when lymph nodes are also removed, as well as 3 centimeter of the liver resection, lymph node clearance is in the conditions of when CA gallbladder is extended beyond the mucosa up to the mucosa. Simple cholecystectomy is performed. Other conditions beyond the simple beyond the mucosa, extended or radical cholecystectomy is performed. So I have simplified all these operations. Prophylactic cholecystectomy is when is performed for gallbladder polyp more than 1 centimeter. Prophylactic cholecystectomy is performed. Typhoid cholecystitis, ultimate solution is cholecystectomy refractory to the medications. Now after going through laparoscopic cholecystectomy, which is a very important talk station, I have discussed acute cholecystitis, in which I have discussed the cholecystectomy operative part, but there are 4 principal management of acute cholecystitis when you are not performing surgery and you are putting the patient on conservative management. 4 principles. You have to keep the patient in PO till his fever settles. You have to give him painkiller as well as antibiotics, cefuroxime 750, cefuroxime 750 mg, Zanesef, painkiller, Zanesef, keeping a patient NPO, preparing the patient, and after the patient is prepared, observing him after that, when his fever has settled, deciding based upon the ultrasound findings, or in case of complication you have to do CT scan. In case of there is a dilated CVD, you have to go for MRCP, RCP, jaundice, ERCP. These are the plan of management. Now, when there is a stone in the CVD, what will be the plan of management? Patient presenting with obstructive jaundice, first his jaundice will be settled, coagulopathy, antibiotic, hydration, relief of jaundice by ERCP is the main management we have to follow. Without obstructive jaundice, just present here, discover incidentally during cholecystectomy, or you have done intraoperative cholangiogram, or in which you have discovered stones, what will be your plan of management? Okay, so the main plan of management is ERCP. Facility available. ERCP is the main plan of management. Stone with structure or CVD dilated more than 2 centimeter, then you have to do choledochoduodenostomy. Choledochoduodenostomy or transduodenal sphincteroplasty you have to do. These are the plan of management. Patient in cholangitis, ERCP to reduce the obstructive jaundice as well as the cholangitis. Patient without cholangitis, you can do laparoscopic cholecystectomy as well as laparoscopic CVD extraction. Laparoscopic facility not available, you can go for open cholecystectomy and CVD exploration. I have covered much of the topic of cholelithiasis and cholecystectomy. Now I will go for another topic, that is breast lump. Breast lump can be benign, can be malignant. Benign on biopsy will be B2. Core biopsy we do as a triple assessment for breast lump. It will be B2, benign. Fibroadenoma, fibroadenosis are included in that benign cyst formation. Malignant will be 5A, 5B. 5A is in situ, 5B is invasive. In situ, lobular carcinoma in situ, which is bilateral, multifocal, lobular carcinoma in situ, ductal carcinoma in situ, all these are 5A in situ, not crossing the basement membrane. Invasive lobular carcinoma, invasive ductal carcinoma, 5B, cross the basement membrane. These malignancies arise in the terminal duct, lobular duct units. Terminal lobule duct units, they arise, and this is the main biopsy, true cut biopsy finding. B9, B2, B3 is a hyperplastic conditions. Fibroadenoma, fibroadenosis, ANTI, periductal mastitis, lumpness of the breast cysts, all these are included in benign conditions. Malignant, I have already told about. Other conditions, breast lump can be inflammatory, in which you have to see whether mother is lactational or non-lactational. Lactational breast abscess is something else. Non-lactational is due to ductal ectasia, periductal mastitis. Treatment of both, especially the above one, it passes through cellulitis stage, then is abscess formation stage. In the cellulitis stage, you have to give cloxacillin plus flagyl, cloxacillin plus flagyl. In the abscess, repeated aspiration, ultrasound guided, failed ultrasound guided IND with periareolar circumlunar incisions are the ideal incision for drainage of the breast abscess. Cellulitis stage, cloxacillin, flagyl, repeated, you have to go for that. Management of this other abscess is a little different. Cloxacillin plus flagyl you also have to give in this condition as well. Once the abscess is settled, treatment is Hadfield major ducts resection operation. different from the above one. Periductal mastitis, there will be nipple retraction, discharge, ductal ectasia, smoking history in the females will be there, non-lactational. Antibiotic treatment is same, cloxacillin and flagyl, but operator management is different. Repeated respiration ultrasound guided, IND, Hatfield major duct operation in periductal mastitis. Now, breast lump can also present with mastalgia, pain in the breast. It can be, you have to maintain the pain chart, cyclical related to menses, non-cyclical not related to menses. Cyclical is related to menses, non-cyclical is not related to menses. Cyclical management is evening Primrose oil, Frescarose 500 mg BD, contraindicated in pregnancy. Vitamin E is here. Cyclical mastalgia with breast lump. Frescarose evening primrose oil. Non-cyclical is due to musculoskeletal problem. Dicloran, paracetamol, or if there is a trigger spot, you can injection Kenacort, injection Depometrol. You can hit that trigger spot with the steroids, pain will go away. Breast lump can also present with nipple discharge. Nipple discharge. Important is whether it is arising from the single duct or multiple ducts. If it is arising from the multiple ducts and it's non-bloody, don't worry about. If it is bloody, if it is arising from the single duct, it is duct papilloma, precursor of late malignancy. You have to do microdecotomy. If it is arising from multiple ducts, you have to exclude malignancy. And after excluding malignancy, operative procedure is Hatfield major ducts resection procedure. So you have to look for blood and cytology. There are 15 to 20 lactoferous ducts. All these are measured as much as they can be removed. They are removed. Now, benign breast diseases. B2. Important one are fibroadenoma, fibroadenosis, breast cyst. Fibroadenoma is also called breast mouse. It has mobility irrespective of the breast tissue, unlike malignancy. Breast mouse. Giant fibroadenoma is greater than 5 centimeter. It is giant fibroadenoma. It must be enucleated. Giant fibroadenoma, wide local excision. It is in the 20 college age group, and when it is more than 3 centimeter, age is 30, it must be wide locally excised fibroadenoma. Giant fibroadenoma more than 5 centimeter. Indication greater than 3 centimeter, age 30. Especially age group in which it's also called breast mouse, and college age group it has its presentation. Fibroadenosis main age of presentation is 20 to 40. There is no discrete lump in the breast, but breast feels heavier, and then there is lumpiness of the breast. Main treatment is a reassurance of the patient, and when nothing can be done, then we have to go for operative management. Breast cysts are rare. They are in the 40 to 60 age groups mainly. 20 to 60 age groups. It can be aspirated when there is a suspicion of malignancy. Biopsy can be taken, or it can be excised. So these are the benign breast problems. Fibroadenosis is included in the ANDI. These are all ANDIs, aberrations of normal development and in evolution, and they are classified as per Cardiff classification system. They can be borderline malignant, ultimately changing into malignancy. But there must be family risk factors and other things. Then is the phyllodes tumor, uneven bosselated surface, ulceration of the overlying skin, not fixed to the heaviness of the breast, huge breast compared to the other side, ulceration. When you pass the probe, it will not be fixed to the deeper breast tissue. It is divided into the benign, borderline, malignant. Benign can be enucleated, wide locally excised. When it is recurrent, malignancy suspicion, massive mastectomy. There is no involvement of the lymph nodes. Lymph node dissection is not done. Breast lump. You have to take history about the lump, how it was noted, then initial how it was, what was its size, now what is its size, whether there was rapid progression, any other lump in the opposite breast, in the neck, or any other metastatic symptoms, any changes in the skin like nodule formation, like ulceration, and any changes in the nipple areola complex like nipple retraction, destruction of the nipple, Paget's disease. All these must be asked in the history. And when there is a breast lump, the most important history you must take is family history, whether it is familial, whether patient is pregnant now, because it will help you in the management. Familial breast malignancy, it is related to BRCA1 and 2, especially 1. And in pregnancy, line of management is different from non-pregnant ladies. So we will discuss them step by step. Uh, Initially, I have just to give you an outline. B5, you have taken history parts I have told about. You have to ask about the breast lump. You have to exclude the risk factors like familial history. You have to completely take the history of when her first menarche age was, when she got married, what was the age, her age at the birth of her first baby, whether she has breastfed all her kids or not, she has used any oral contraceptive pills, her sister, mother, grandmother, any suffer from any breast lump, whether she was treated, she is alive now, any radiation therapy to the chest region. These must be asked from the patient, and at the same time you have to exclude the locally advanced from the early and from the metastatic breast. These points are, uh, if you miss them, they will kill you. Simple as that. B5A, B5B, in situ invasive. Lobular carcinoma in situ, ductal carcinoma in situ. Lobular CA, invasive ductal CA. It is bilateral, bystander lesion, multifocal, and it can be treated by tamoxifen. Tamoxifen for 5 year, 20 mg BOD for 5 year, tamoxifen 50% reduction in lobular carcinoma in situ. Ductal carcinoma in situ is treated by von Neon's prognostic criteria, in which if it is from grade 5 to 3 to 5, 6 to 7, 8 to 9, management changes. 3 to 5 you can only do wide local excision. 6 to 7, it is depending upon the size of the lesion, its histology as well as resection margin. Then you can add radiotherapy with that, and if it's 8 9, you have to do simple mastectomy. Plus nowadays this is sentinel lymph node biopsy. You must do, you have this one MCQ is covered here. Mastectomy, simple mastectomy plus sentinel lymph node biopsy you must do. There is no information on mammogram of lobular carcinoma in situ. A ductal carcinoma in situ is easily picked in a form of the Reckitt single duct pathology. It is easily identified. Then is the invasive lobular CA, as related to E. cordiorin mutation. We are more interested in invasive ductal carcinoma. They are specific, non-specific. Non-specific we are more interested in. Straight away I am going to the our important topic of early breast CA, locally advanced breast CA, metastatic breast CA, familial breast CA, recurrent breast CA, and recurrent familial and pregnancy related breast CA. I will discuss them in my next video. So far, but a little, if it is less than 5 centimeter, no skin, no nipple areola complex changes, and one mobile lymph nodes are there, it is early breast CA. Less than 5 centimeter, mobile axillary lymph nodes, no skin changes like nodule formation, ulceration, fixity to the chest wall, fixity to the ribs, intercostal muscles, no changes like that. It is early breast. It is stage 1 and 2 as per Manchester classification, stage 1 2. Locally advanced, there is more than 5 centimeter and 2 and 3 nodal involvement. Fixed lymph nodes are there, fixed axillary lymph nodes are there, supraclavicular lymph nodes are there, internal mammary lymph nodes are there. It's N2 and 3. Skin changes are there in a form of odorange, nodule formation, ulceration. These are 3 changes which are included in skin. Twittering and dimpling are not skin changes. They are not skin involvement. Nodule formation, ulceration, and podorange appearance is skin change. Nipple areola complex changes like retraction of the nipple, discharge from the nipple, these are included in nipple areola. Destruction of the nipple, skin changes are there, but it is different from metastatic, in which metastatic it must fulfill the LLBB criteria, like bony involvement must be there, femur, humerus involvement, lung involvement, pleural involvement, pleural effusion must be there, brain involvement must be there, liver, lung, bone, and brain. Then it becomes metastatic. We have to use chemotherapy, radiotherapy, and whether it's surgery. So breast lump is a multidisciplinary MDT cases, early, advanced, metastatic, all. Familial are changes, they are related to metastatic. LLBB criteria must be there. Familial, they are BRCA1 related. Recurrent, there it is different, its management is different. I will discuss them in detail. And in pregnancy, how you will manage. In pregnancy, I must give you a few points before ending this video to make it not boring, because I know it's a very boring topics. Pregnancy, you have to do surgery in second trimester. You can give chemotherapy, but chemotherapy is not CAT regime. It is CMF regime, not CAT regime. CAT is adriamycin, cyclophosphamide, taxanes are not given in the pregnancy. It is CMF regime. Hormonal therapy is not given. Radio therapy is cannot be done. Moreover, only ultrasound is done. Other methods of identification are not done. In case of after pregnancy, patient has to wait for 2 years after the treatment of breast CA for next pregnancy, and if she is using oral contraceptive pills or other things, she has to stop that. You can give stop her lactation by giving bromocaptine. So I will end my lecture here. Inshallah, in the next lecture we will go to discuss it further, because it's a very important topic, and I will try my best to cover the most important aspects of these topics, so that you don't have to search for multiple books and finding some point from there. I will give you crystal core knowledge of each and every um, aspects of the topics in a very crispy and concise manner. Thank you, and keep watching my channel, and please like and subscribe my videos. Thank you so much. Bye.